Thank you. Assalamu alaikum, everybody. Okay, so I have a conflict of interest to declare, which is that I continue to support Manchester United despite Mohamed Salah destroying my team on this Sunday. But life is like that sometimes. Okay, so Andrew spoke in a general way about diabetic neuropathy. What I'm going to do is hopefully take you from practicing or understanding diabetic neuropathy from a better way of diagnosing diabetic neuropathy, okay? And also actually a better way of assessing it in the clinical trials. So when we look at the three complications of diabetes, for retinopathy, we have really very good way of detecting early disease. And it's very easy. You take a picture of the back of the eye and you have diabetic retinopathy. Renal dysfunction, microalbuminuria, GFR, very easy. For neuropathy, we actually have a problem, and that is that the diagnostic approach is completely wrong. In that, this is not working. Maybe this. Okay. Yeah. In that, we focus very much on these fibers, which are the large fibers, the A beta fibers. Because all these techniques, neurological examination, monofilament, vibration perception, neurophysiology, are all focused on these A beta fibers. Now, what's wrong with that approach? The primary problem is that the A beta fibers are damaged late in the disease process, and it's really the C fibers that are damaged the earliest. So if you want to diagnose diabetic neuropathy at an early stage, you have to be looking at these small C fibers. And how can we do that? Well, I'm going to share with you really how we might be able to use this ophthalmic technique called corneal confocal microscopy to actually diagnose diabetic neuropathy. And so this is the technique which we came across about 20 years ago. And what it is an ophthalmic technique that allows you in real time to picture nerve fibers, small C fibers in the cornea. And we showed or have shown that you can scan through the cornea, come across these nerve fibers, measure these nerve fibers, and quantify diabetic neuropathy. Okay, so it starts off with a crazy idea in 2003 when I was still a young registrar with Andrew Bolton, where we took 18 patients with different degrees of diabetic neuropathy, mild, moderate, and severe, staged according to nerve conduction, vibration perception, and neurological exam. And we performed corneal confocal microscopy. And what you see here is a healthy control, and these white lines are nerve fibers. What you see here is a patient with advanced neuropathy, where you can see there is this extreme loss of nerve fibers. And if you measure this, whether it's nerve fiber length, fiber density, or branch density, what you see is that in people with severe neuropathy, there is clearly a marked loss of these nerve fibers. But what we have shown is that actually even in patients with very mild disease, we're actually able to detect loss of these nerve fibers. And so we believe that based on this study, that we could use this test in a rapid way to pick up early diabetic neuropathy. And alhamdulillah, following on from that, over 20 years of work, 38 studies, over 4,000 diabetic patients, and this meta-analysis that's recently been conducted by one of my PhD students, Hoda Gad, shows that we are able to differentiate people with diabetic neuropathy from controls highly significantly, but also we can differentiate people with what we would consider as having no diabetic neuropathy based on neurophysiology, vibration perception, and neurological examination, they also have a lower corneal nerve fiber count. But not just diabetes. What we have also been able to show is that people with impaired glucose tolerance actually have loss of small nerve fibers in the skin, but also in the cornea. You can see that there are less nerve fibers and there are finer nerve fibers in people with impaired glucose tolerance. And you can see this is actually significantly reduced for 3 different measures: nerve fiber density, branch density, and length. Moreover, if we think about painful diabetic neuropathy, we know that painful diabetic neuropathy is because of damage to the small nerve fibers. So it's no point doing a monofilament exam to diagnose painful diabetic neuropathy. What you need to do is measure the small nerve fibers. And if you do that, what we were able to show is that if you take people with painful diabetic neuropathy, they have less corneal nerve fibers compared to patients with painless diabetic neuropathy compared to healthy controls. So that's for nerve fiber density, nerve branch density, nerve fiber length, and inferior wall length. This was in one cohort of patients, and subsequently in a separate cohort, actually we've shown the same, but what we also showed is that the extent of nerve fiber loss relates to the severity of pain and the quality of life in these patients. And in a separate cohort, we have shown exactly the same, that those with painful diabetic neuropathy have lower corneal nerve fibers compared to painless diabetic neuropathy compared to healthy controls. Moreover, erectile dysfunction is one of these conditions that a lot of our patients have, and we rely on symptoms, but we also know that there's an underlying basis for that. And most physicians will think about, which hormone do you test? Testosterone, right? You think maybe I can do testosterone. Well, we had a cohort of people with diabetes, and we looked at the total testosterone and the free testosterone levels in relation to the severity of erectile function. And actually, apart from those with very severe erectile dysfunction, we really didn't find very much difference in terms of the testosterone levels. However, when we did corneal confocal microscopy, what you see is that even in the early stages of erectile dysfunction, there is a loss of small nerve fibers, and this is of course most severe in those with most severe disease for both corneal nerve fiber density and corneal nerve fiber length, suggesting that CCM could be used as a marker of erectile dysfunction and also severity of erectile dysfunction. And of course, to measure all these things like nerve fiber density and nerve fiber length, it often actually takes a lot of time by my team, my research team. So what we've now developed using artificial intelligence is a rapid, automated way of classifying nerve fibers or classifying people into those with and without diabetic neuropathy by simply a computer looking at those images without me having to measure anything. And so what we've used is this logic-based fuzzy inference, which is a deep learning method, which looks at the nerve images, and it actually does some amazing complex mathematics and is able to classify patients into whether they have or they don't have diabetic neuropathy. But not just classify with a reasonable predictive value, but actually with an AUC of 1.0, which is 100% sensitivity and 95% specificity for differentiating healthy controls from diabetic patients with painful neuropathy, with the neuropathy. And now I put up this quote by Thomas Campbell, who said, "Coming events cast their shadows before." And Andrew often uses this quote to kind of, I suppose, highlight that neuropathy predicts foot ulceration and amputation. What I want to talk about is this. And this is actually topical because COVID, I believe, exacerbates existing neuropathy. So if you have a patient with diabetes and diabetic neuropathy, if they have had COVID, they are at higher risk of worsening their neuropathy. And what we have shown is that if you get somebody who's had diabetes, and actually even without diabetes, and they get COVID, what happens is that their nerve fibers become more damaged. And we came across this actually in an initial case series that was reported with a group from Barcelona, where we showed that 4 patients who had severe COVID who were intubated. Oh my God, I don't know what's happened here. You'll have to believe what I'm saying here, but this has been, I don't know why. But so we had a series of 4 patients who developed severe COVID, and then they also developed pain and numbness. You can see all 4 patients, and they lost their taste and their smell. And when we examined them using quantitative sensory testing, we were able to show that actually they had marked abnormalities of vibration perception, cold perception, warm perception, and heat pain, all measures of small fiber damage. Now, subsequently, we've actually now done a study in people without diabetes, young people who developed COVID, mild COVID, and what we did is we performed something called a long COVID questionnaire, which is basically a nice approved questionnaire which looks for persisting symptoms after recovery from acute COVID. So these include musculoskeletal, respiratory, cardiac, but particularly neurological symptoms. And what we were able to show is that a proportion of patients, about 20%, developed something called long COVID, and they had more neuropathy and they had more musculoskeletal symptoms. More importantly, when you actually did the corneal confocal microscopy, so these are fit, healthy individuals who had no neuropathy before, but yet look at their nerve fibers. They had a loss of nerve fibers, particularly those that had long COVID, not those that did not have long COVID. And if you look at their counts, you see those who had long COVID had lower corneal nerve fibers, but they also had these little dots, which are basically immune cells that were present 4 months after recovery from acute COVID. So, can we use, or is there anything we can do for diabetic neuropathy, or do we just diagnose it and commiserate with the patient? And somebody asked this morning, what can we do for a patient with diabetic neuropathy, apart from symptom control? So here I would like to suggest to you that there are things that we can do for diabetic neuropathy, and these include the following, because we know that the following are risk factors for diabetic neuropathy. And these include hypertension, smoking, glucose control, being overweight, having higher triglycerides, and having total cholesterol. Now, the problem here is that whilst we know these risk factors cause diabetic neuropathy, most of the clinical trials that have been done in this area have been negative to date. So can we address that? I believe we can, but we have to have the right tools. So we have to have tests that can actually show nerve fiber repair. And I can tell you, neurological exam, symptoms and signs, neurophysiology have all failed. So we have done a proof of principle study in people with type 1 diabetes who underwent pancreas and kidney transplantation. So you can imagine, this is a type 1 diabetic patient who's end-stage renal failure, who requires a new kidney, but we also at the same time put a new pancreas in and cured their diabetes. And what did we find? Well, we showed actually that at baseline they had very few nerve fibers, but over a period of 36 months you start to see this repair of nerve fibers. And in fact, if you look at their corneal nerve fiber density, at 12 months there is a significant increase, at 24 months there is a significant increase, and at 36 months there is a significant increase. The same with corneal nerve fiber length. However, if you look at their symptoms, really, actually there is a reduction, but only at 36 months. And if you look at their nerve conduction, again, that takes about 36 months for perineal nerve conduction to improve, but the amplitude, serial nerve amplitude, does not improve. So if I had done a clinical trial to look at the effect of pancreas transplantation using symptoms and signs and nerve conduction velocity and amplitude, I would have said doesn't work. But you can see that it does work, and there is repair of nerve fibers if we use corneal nerve fiber length. The other thing that we've now been able to look retrospectively is in relation to this. So you'll be aware of the LEADER trial, which was a GLP-1 therapy trial with liraglutide that showed impressive benefits for cardiovascular outcomes. A sub-analysis of this study, actually published in Diabetes Care, showed that liraglutide reduces amputations in patients with foot ulceration. So actually it was able to show that people who developed a foot ulcer during the trial were less likely by almost 35% to have an amputation. So you could actually limit this amputation. And you might think, so why could that be? What could be the underlying reason for this? Well, we actually in Qatar were able to look at this because we were part of a trial that we looked at in type 2 diabetic patients who were poorly controlled, comparing exenatide with pioglitazone to a basal bolus insulin regimen. And what you see here is that at baseline they had a HbA1c of 10%, but you can see that they improved their HbA1c by almost 3%, both groups. But they actually also gained weight. You'd expect GLP-1 therapy, once weekly exenatide, to lose weight, but because they were on pioglitazone, they actually also gained weight. But despite this, you can see that actually corneal nerve fibers repaired in both groups, unlike vibration perception and pseudoscan. And if you look at lipids, we know triglycerides and total cholesterol are important, and so we also know from the fenofibrate field study that if you give fenofibrate, you can reduce minor amputation by almost 50%. Again, we've had the opportunity, or others have had the opportunity, to look at omega-3 supplementation. You know, omega-3 lowers triglycerides by 30%. And what have they been able to show? Well, after 8 months, there is an improvement in neuropathy because corneal nerve fiber length and overall change is increased significantly. And more recently, just published in Diabetes, is another trial with omega-3 supplementation, which looked actually at MNSI, MDNS, quality of life, QSART, perineal, tibial, sural nerve conduction, median nerve excitability, showed absolutely no benefit after 12 months. However, corneal confocal microscopy improved significantly after 180 days, as did the branch density and length. Again, arguing that this is a sensitive endpoint in a clinical trial. Finally, we know statins can reduce sensory loss and erectile dysfunction in a cohort of patients. So we've had the opportunity, there was a symposium earlier with PCSK9 inhibitors. So PCSK9 inhibitors are of course very good at lowering total cholesterol. In obese subjects, we were able to show actually that there's a relationship between PCSK9 levels and small fiber damage. Furthermore, in a trial of people with familial hypercholesterolemia with avilocumab, we have actually now shown that patients with FH have lower nerve fiber counts compared to healthy controls, but after 12 months of therapy of avilocumab, there is an increase, an improvement, a significant increase in corneal nerve fibers. Finally, BMI, we know is important, and what we've now able to show on 2 different studies is bariatric surgery, the benefits of bariatric surgery. So this is a cohort of people with obesity, without diabetes. What you see is just obesity alone causes small fiber damage. But 12 months after bariatric surgery, there's actually a significant improvement in corneal nerves. In a cohort with diabetes, again, we were able to show after 12 months an improvement in corneal nerve fiber density, branch density, and corneal nerve fiber length. And I'll finish off actually with a case of a 36-year-old Asian male who happened to see me because I play football with him. And he was a little bit overweight, and he said to me, "What can I do, doc, to help?" right? And I said, well, you can go on a diet. And he said, well, you know, I've always had a problem that everybody in my family has diabetes. I'm overweight, 96 kilograms, but my HbA1c is 5.2%. So physicians won't prescribe for me anything to lower my glucose because my glucose is normal. And he said, I've been on diets. So this is actually, if you look 2016, 17, 18, 19, 20, 21, this is the typical journey of a person who's overweight. What they do is they gain weight. Then they go on a little diet, they lose weight, then they gain weight. They lose weight, they gain weight. They lose weight, they gain weight. Then something here happened, something magical. And it was that actually I said to him, okay, you can buy this. This is semaglutide, the once weekly. And literally when he went on it, he lost 18 kilograms without changing his HbA1c. And look what happened to his corneal nerves. Actually, at baseline, he had lower corneal nerves compared to controls, and you can see they started to repair within 3 months. Thank you.
Thank you, Professor Rayaz, for this elegant, interesting lecture. I have some questions for you, please, if you allow me. The first thing is, all of us know that the definition of diagnosis of diabetes is depending on the earliest change which is happening in the retina. Can we use this CCM or do you have any studies about if there is any earliest change, who is appearing first, the change in the retina or change in this nerve? This is the first question. And the second question, what's the clinical significance of the nerve fibers improved in the cornea, although the peripheral sensation is not regained? The most of the morbidity and the most of amputations and the diabetic foot ulcers and everything is happening from loss of the peripheral sensation and motor sensation. Do you think what's the clinical significance if the picture is changed in the cornea without changing in the periphery?
So first of all, in terms of the retinopathy compared to neuropathy, what we've shown in 3 separate studies now is that corneal nerve loss occurs before the earliest change in diabetic retinopathy. And now actually we believe that it is a better marker of diabetes cutoff than probably retinopathy. 2, in terms of your question about this being relevant to what's going on down there, we have done separate studies, which I wasn't able to share, that shows that what we see here, and we take a skin biopsy from the foot, is actually the same picture. But more importantly, from the pancreas transplantation study, we were able to show that corneal nerves repair after 12 months, but the symptoms and neurophysiology actually improves after 36 months. So there is a relationship, but it's just delayed in terms of the periphery. I think the peripheral nerve damages does repair, but it takes a lot longer to repair. We just think that this is an earlier signal here.
Yes. Okay. Can you do it in any time in the diabetes, or the patient, for example, must be controlled? I mean, if the patient random blood sugar now is 400 milligram, is it the same picture while it is 180? Does it change? I mean, this may affect the permeability of the cornea or do some refractions?
So we haven't seen any direct relationship with the plasma glucose levels and, you know, acute glucose, as you say, if it's 400 compared to 100. We haven't seen an acute relationship. There is a long-term relationship with HbA1c, but not with acute glucose.
Yes, thank you. Any questions from the floor?
May I ask a question?
Professor Muhammad Hassanin is a chairperson virtually now, and he wants to ask you a question.
I know what he wants to ask me.
Okay.
I know, he's a Liverpool fan.
Yes, but...
no football questions. Riyaz, this is fascinating work.
هتجيبوا صورته؟
Yeah.
ولا إيه؟ Okay. You
Yeah.
know the question.
Oh, I know. I
Okay.
know, Muhammad.
Riyaz, this is fascinating work. What do we need to do to establish this investigation as a parameter for that glycemic control can improve neuropathy? Because the previous work, as you've highlighted, doesn't show that there is much we can do. But in your study, as well as the anecdotal cases, there is evidence. what is required to go to the extra mile to get that established in the guidelines?
I mean, I think is acceptance of this technique actually alongside, for example, retinal screening. And I think, you know, we now, before people used to say, well, you've done a study with 18 patients, but we now have this meta-analysis that shows we've got 4,000 patients that show exactly the same. So I think that acceptance is going to come, inshallah, but you know, the problem is it's just people getting their head around measuring something in the eye, reflecting something in the feet. It will happen before I go old and really grey.
No comments. Thank you. Thank you, Riyaz.
Thank you.
Question. كان دكتور كان حضرتك تسأل؟ مايك هنا لو سمحت. دكتورة وبعدين دكتور. دي واحدة فين لما نجيب لحضرتك المايك اهو.
Thank you for this lecture. So I ask for corneal confocal microscopy technique for diagnosis في nerve damage وhow to برضه technique for erectile dysfunction fibers technique. You see picture?
Yeah.
Corneal.
Yeah.
What is the, I want to see is this technique for nerve fibers. What is illustrated برضه also على erectile dysfunction fiber. Thank you.
I don't understand. What is the technique?
Technique of what?
Of corneal confocal like a
Corneal?
corneal confocal diagnosis for
corneal.
جاب البيكشر على العين ده. احنا عايزين هنشوف التكنيك على النيرف فايبر.
لا هي من الكورنيا بس. هي من Doctor is asking, if you are examining the nerve, small nerve fibers in the erectile dysfunction, it was thought that it is in the penis itself or the genitalia itself. It is the same in the eye only. He's asking, do you have any methods for examination in the nerve fibers and the areas of the genitalia?
In the rest of the body?
Yes.
No. I mean,
No.
not in vivo like this. That's the whole beauty of this cornea, that it allows light through, so we can utilize that, and just the optics allows us to do that.
Yes. Doctora Aniba?
Thank you for this nice presentation. I will ask, before we have been told that retina is the mirror of diabetes in terms of diabetic retinopathy. But finally, we note that we could have diabetic nephropathy without diabetic neuropathy. So can we use this new technique while we look into the cornea? So we suspect that the presence of microangiopathy with this this new technique. And is there any day we will discover that this is not the whole story for the microangiopathy?
So what I can say is that we have studies where we show that corneal nerve loss occurs before patients develop diabetic retinopathy and before they get microalbuminuria. So we believe this is one of the earliest stages of tissue damage in patients with type 1 diabetes and type 2 diabetes. And also, actually, I didn't share the data with you, we have got 3 separate studies now that show that if you have a low corneal nerve fiber count and you have people without diabetic neuropathy, after 4 years, those who develop diabetic neuropathy have a lower count compared to those who don't. So it actually predicts the development of clinical diabetic neuropathy as well.
So it's not just diagnostic,
Oh yeah, it predicts.
even predictive.
Yes.
Okay. Thank you.
Is there any role for the alpha-lipoic acid for improvement of diabetic neuropathy?
I only wish that they'd use corneal confocal microscopy in the alpha-lipoic acid trials, because I believe that they would have shown a benefit, because in the alpha-lipoic acid, the one big trial that was done for 4 years, there was a signal that nerve conduction improved after about 4 years. But it was a slight improvement. So I think if we'd used, CCM, we would have shown nerve repair. Yeah.
Thank you very much,
Okay, thank you.
Professor Rayaz.